Very good evening to all of you. I welcome you all for this What is Expert Say session of EOS in India. Today we have interesting talk on minor traumatic brain injury. Request the President Shafali ma'am to introduce the speaker for today, the moderator and expert for today's session. Over to you.
Yeah, thank you. Thank you. Welcome you all for this yet another session. Now this one will be on what do experts say. When I met Dr. Elsie in Cape Town, I remember Biju having said that Shefali didn't find head injury enough to have an SIG. The problem what we had only 9 SIGs possible. So what we decided now, so all the important contextual ones will come up in the picture. And I think Dr. Elsie will request you to come back after 2 months for humanism, because Namaste is something important and close to my heart. So here we had the topic is mild traumatic brain injury, not always so mild. It'll be such an interesting topic. And the speaker is Dr. Elsie Arturs, who is globally renowned. He's Associate Professor of Pediatrics and Neurology, Boston University, and School of Medicine, and Director of Pediatric Brain Brain Injury Program. And is a specialist for traumatic brain injuries and pediatric neurological disorders, and lots of publications, and serves on the editorial board of Journal of Pediatric Neurology, Child Neurology, and is active in national and international organizations, including the Child Neurology Society, AAP, Brain Injury Association, and the ICNA, and also the Ibero-American Academy. Thank you so much, Dr. Elsie, and good morning. Thank you so much for having joined. And the experts for today, as we have Dr. Biju Hamid, I'm not going to introduce. Everybody knows him, synonymous with ICNA. Yeah, but now he's in addition Gush and UA both. And Professor Hassan, our dear friend, also has been introduced innumerable times. And I think I will not, everybody knows him very well. And then our third expert who is about to join is Professor Deepak Gupta. Thanks, Dr. Deepak. He just came out of the OT, so that's why he's a neurosurgeon. He's a pediatric neurosurgeon. He's professor in Department of Neurosurgery at AIIMS New Delhi, a very dear colleague. And we've been working on traumatic brain injuries in addition to many other pediatric neurosurgical things. We had some DM dissertation on this thing. He's focused on pediatric neurosurgeries, and we were part of the team which he led for separating 2 sets of craniophagus twins, and which is in the LIMCA book of records. And he has 360 original publications. And to moderate the session, we have our alumnus, Dr. Arvinder Wander, who just left us 2.5 years back, and now he's become the head of pediatrics at AIIMS Bathinda, which I'm very happy to say, and very good alumnus, a very hardworking senior person, and he has been working with a lot of interest in neurodevelopmental disorders and also brain injuries. And he's getting a lot of brain injuries in Bathinda because brain injuries are coming to pediatrics there. So that's why he's getting a lot of exposure. And 32 publications he has. So over to you, Arvinder.
Yes, ma'am. So without wasting time, I would request Dr. Elsie, if you can start the talk, and then we will proceed with the cases. So we have 2 case presentation afterwards, and so the screen is yours, Dr. Elsie.
Sure. Thank you so much, Dr. Shefali, and all the organizing committee, Manesh, Biju, Hassan, and Dr. Gupta, and so many others, of course, Arvinder, who has been always in contact with me throughout the year, talking to me about this, the context of this meeting. So thank you so much for having me here. It is a pleasure and honor, and I would like to talk to you about a topic that is very deep to my interest, traumatic brain injury. And I'm going to talk about the mild traumatic brain injury, or that was something we call concussion. But I just want to give you the idea at the end of the presentation that this is not always so mild as it looks like in the numbers. I also would like to say that it doesn't matter that this is focused on this area, but at the end, we would like to ask questions about any parts of the traumatic brain injury. I'll be happy to address. I don't have any conflicts of interest for these minor contributions from Elsevier due to publications and advising the international organizations of soccer and several groups here of research and traumatic brain injury, but no conflicts academic or financially for this lecture. The objectives.
Elsie, your slides are not shared.
Okay, let me go back.
You have to share the screen. I mean, I think we've forgotten the.
All right. What about there? Can you see them?
They're not yet, yeah, perfect, perfect.
Okay, good. So, again, sorry about that. So my objectives today are to describe the physiological changes associated with concussive brain injury and how they relate to clinical relevant sequela, to properly identify and assess the child and adolescent with mild traumatic brain injury or concussion, to develop a management plan and understand limitations of the evidence, to become familiar with available resources and evidence-based guidance for concussion care. Humanity is very familiar with traumatic brain injury. For those familiar with the Catholic Bible, you will recall this scene in which the bad brother kills the good brother, Abel, by an impact of a stone, as the tradition tells. Then later on, also in the Bible, there is this famous episode in which David beat Goliath with a stone from far away, and this was directed again towards the head. So the people were, even many years ago, aware of the susceptibility or vulnerability of the brain to traumatic brain injury. In a visit after the last Congress in Antalya, I went to Santorini, and I find out that there is these frescoes, these paintings on the old city that was buried after the explosions of the volcano in the island. And if you can see there, there's two youngsters that are, in this case, playing a sport, the boxing. And as you can see, the hands were covered with some type of protection. So they were aware that it hurts and it caused damage, but there were some concepts about the need to protect. And if you continue on the left lower picture, you see this is a statue portraying some of the players that were in one of the old Olympics in Greece involved. And as you can see, in this case, they actually removed the protection for the hands. And the idea was that for boxing to be attractive or for these type of sports, they need to actually produce injury, bruising, bleeding. Later on, and this is not too long ago, you can see in the middle, Cassius Clay, later on, Muhammad Ali, one of the legends on the sport that was revered in not only in the United States but around the world. Here beating Joe Frazier and being on the cover of the magazines. So we have had to come a long way to understand that injury to the brain, it is not fun, it is dangerous, and that we as a society need to do something about it. But as a product of that, there's a lot of research going on. And as you can see in the right lower picture, there is a device, electronic device, to measure the intensity, the directions in which athletes can get injured. At the beginning of this talk, I usually like to talk about some numbers. Traumatic brain injury represents about 30% of all injury deaths. Every day in the US, about 157 people die from injuries that including brain injury. Fortunately, in a way, most of the TBIs are considered mild or concussions. However, up to 13% of these patients continue to develop symptoms for periods of time that are beyond weeks, months, and some of them even years. Anybody who works in a hospital needs to be familiar with traumatic brain injury. About 2 million people will present to an adult ER, close to 1 million, and children will be seen for this. And this is only in the US. About 15 to 20% will be admitted to the hospital because they lost consciousness or they are not doing too well. And about 0.5% of people will die. Now, when I'll give you the percentage, it would appear that this is a small percentage, yet when you think on the numbers, think about it, 3,000 children that you could have prevented dying, then it tells us that we still have a long way to go. In my hospital, we can compare sports-related injury on the left with non-sports-related injury on the right. And you can see, according to this study, that about 90% of the sports people are younger than 23 years of age, whereas in the other side, in the other column, it is a 50-50, and this is because of what happens at the end of life when we get older, as we're going to see later in a minute. As you have seen, there's there's a very large number in countries that are industrialized over sports-related injury. And in America, American football continues to be the highest source of concussions, followed by other sports like hockey, soccer. But this is, as you're going to see, even in other sports like cricket, for instance, you're going to see that concussions can occur. And I mentioned cricket because I know that that's a popular injury, a popular sport in India. There are in girls, though, basketball and soccer are the top leading sports that can cause an injury such as concussion. Now, anybody who works in pediatrics needs to be familiar with these curves. As you can see in the continuous curve above, there is always, this is what happens with traumatic brain injury across a lifespan. And as you can see, there's always males more predominant than girls. And there are three peaks: pre-adult, preschoolers, toddlers, young people. And there is another peak when you become adolescent or young adult and at the end of life. Now, if you're a pediatrician, these are the peaks that we see the most in our hospitals, with a bigger gap in adolescents and young adults between males and girls, as you can see in the picture. And this alone is the #1 cause of death and disability in kids and teenagers. There are definitely differences between males and females. Females have a higher chances to have abnormal neuropsychological testing and problems with gait after concussion. There is definitely, as I mentioned before, girls that play soccer and basketball are the ones that are more likely to suffer an injury in the US. And interestingly, as you can see in the pictures, this is lacrosse. And as you can see, the injuries are more common in girls than in boys. But look at that, girls play with no helmet. And this is important because sometimes people feel like helmets are supposed to protect for injuries, and they do protect for bruising and fractures and edema, but not necessarily for concussion. This is, if you follow cricket closely, this is a fantastic athlete from Australia, Steve Smith. He gets hit playing in India and then falls down, right? He loses his conscious briefly, and he is being examined by an athletic trainer. And I don't know if you remember the game, but Steve comes out of the game. He's supposedly to go through an evaluation for concussion, and then he comes back to the game and finish the game, only to fail at the next day and had a very lengthy recovery, proving that the silent evaluations are not always correct, and that there's a need for a very good research and also for very good laws that are applied correctly to prevent long-term side effects of this. So there are several definitions of this. In fact, the definition is being updated every 2-3 years in what we call the concussion in sports group. Meets in Europe every 2-3 years. The last meeting was in Paris at the end of 2022. However, I have access to the writings of Denny Brown, a professor in neurology from the UK that came. He was from Oxford. He came then to the US, was a professor of Johns Hopkins, Harvard, Boston University. Those days, if you become a professor in one university, you will keep the title no matter where you go. These days, as you know, if you move from an institution to another one, then you cannot carry your previous title. But coming back to the definition, it is a very simple thing. This is a change that occurs in the brain because of a pathophysiological process caused by traumatic biomechanical forces. And if you look at this definition and compare to Dennis Brown's exactly the same, maybe 2 or 3 words different, but obviously there is not much science in what is a head injury, right? In the case of a mild traumatic brain injury, is a form of traumatic brain injury. It is primarily the results of forces of rotation, and it's considered for concussion that this is a functional damage rather than a structural. But that also, it's a bit controversial because if you are if you are a molecular biologist or a microscopic, electron microscopy pathologist, you can debate that. Now, this is the FIFA, the International Football Association Museum. This was one of the sponsors of these meetings that occurs in Europe. And this group of experts around the world that meeting here, then they try to improve our knowledge or our guidelines on how to manage concussion. It is important to remember that you don't need to be hit on the head to have a concussion or traumatic brain injury. This could be, I have this example of a roller coaster, a girl that goes in a roller coaster, and then after the ride, she loses the restraint of the head, the upper part of the shoulders, and the head went banging, and at the end of the ride, she developed symptoms typical of concussion, was treated for as such, and then we realized that you don't need to really be hit. And this is what happens in sport. Even the video can miss an impact, can miss the rotation of the head of the brain, and yet you still have an injury. And this is important when you take the history, as well as when you try to understand the mechanism of injury. Sometimes it's difficult to elicit. At the beginning, you develop symptoms in the first few hours, even perhaps in the first 1-2 days, but then there should be a spontaneous resolution, provided that this was not a severe impact and that the patient or athlete is doing the right thing. Now, these changes, these clinical symptoms reflect, as we said, dysfunction rather than structural damage, and that the standard imaging will not show any abnormalities. If there is a bleeding or if there is a stroke, then those lesions will take precedence before a concussion be made. This happens on the ICU all the time. It is not that the patients in the ICU don't have a concussion, it's just that there are other injuries that require more attention or emergently. So when we talk, and I'm glad that you probably had already your dinner and everything, and in Boston it is not yet the time to lunch to talk, so I can talk freely about this. So, and this comes from the observation that it was when you sacrifice cattle for meat, for beef, then at the beginning it was the idea that to kill them, you will put a big weight and you will hit them on the side of the head. But if you do that, then you will produce bruise, swelling, edema. The cow was not really concussed, and people start thinking that perhaps this is an inhumane way to sacrifice these animals in the slaughterhouses. By chance, I believe that at some point, the head of one of the cows was free, and then receive an impact. And instead of the bruising that you would normally get, this cow look different, look knockout, look concussed. And this was the basis upon which Denny Brown in 1941 developed the first animal model for traumatic brain injury based on acceleration. I like to talk about this experiment a lot. This is Holborn in 1943. He thought that if you play, I'm sure you all have played when you were kids with Jell-O, or even as an adult, you prepare Jell-O and you push, in this case, for this experiment, Holborn put him on a plastic model and push it linearly and open the plastic model, open the model, and nothing happened. But then he realized this is not what happened in traumatic brain injury. And instead of pushing linearly, he rotated very fast. And in this case, he realized that there was a change on the structure of the Jell-O. He thought that this was the basis of what happens in traumatic brain injury, and actually published his paper in Lancet. Not that it will be that easy these days to do. Omaya and Gennarelli, almost 30 years later, they developed the animal models on Macacus rhesus monkeys, the closest to the humankind, that proved that these theories were correct. if I show you these two pieces of brain, left and right, and I'll ask you which one of them will be concussed, the answer is that you wouldn't be able to answer because, again, the concept is that the damages that occur are functional and not structural. Why is that traumatic brain injury, even though it is a neurological problem, why it is that it has become on fashion these days? Why is that we're talking about in the last 2-3 years and every meeting has tried to include something about traumatic brain injury? It's because there are more people playing sports, there are more people driving cars. India is one of the countries with the largest incidence of motor vehicle accidents in the world, and it's Ukraine and some countries in the sub-Saharan Africa in which this is probably one of the fastest growing areas in terms of traumatic brain injury due to motor vehicle accidents, and that not only in adults but in pediatrics too. We are also more aware about what happens if you continue to injure your head. Our group in BU demonstrated that you don't even need to have a concussion if you are in a profession or have received hits on the head that were soft concussing, we call them. There is a cumulative effect, and you might develop neuropsychiatric symptoms later on. When those hits are significant enough to produce a release of a protein called tau, T-A-U, there is the good tau and the bad tau, and when the bad tau migrates to the periphery of the brain, it likes to be deposited between the cortex and subcortex, and those deposits that looks pretty much like those ones you see in other neurodegenerative disorders of adults or elderly people like Alzheimer's. Those deposits will find the brains don't work the same, and you will have people that even though appear to have everything on the 40s, 40 ages, 50s, they commit suicide, or they kill themselves, or they kill other people. And so this way of the brain dysfunction, it is being called now chronic traumatic encephalopathy, a term that was also coined in our university. We still have, or there is still debate in trying to find the link between what happens in youth. It actually evolves no matter what into CTE. Who are the groups in which this will be more frequent? There's still a lot of science that needs to be uncoded. And then there is, because if you work ever in the emergency room, you're afraid to discharge anybody because of the risk of something that we call second impact syndrome, in which the patient goes out of the emergency room, gets another injury, and then develops this irreversible swelling of the brain that ends up with herniation and death. Now, why should you care about concussion pathophysiology? Because it is related to neurocognitive impairments, and its timing guides recovery expectations. This is my best friend, the neuron, right? Our best friend. It's being hit, but as I said, not always with a hammer like this. And then potassium in, sodium, potassium out, sodium in. And then there is a pump that tries to reestablish equilibrium, but use a lot of the energy. So that means the mitochondria needs to work hard. We're consuming glucose. And when the glucose is gone, then there is an energy crisis. The moment that this happens, the calcium channels open, and then this influx of calcium activates the proteolytic enzymes, the sweepers of the neuron. And at the beginning, it's good. You clean up the dirt, but then if you continue to do this action, then you eventually damage your axons. And if you damage your axons, you alter the propagation of electrical stimulus. You might also release glutamate, cause of seizures in the immediate event. And most recently, we are also questioning the role that blood vessels have when the system feels that there is a problem. So then there is a vasoconstriction. Unfortunately, these blood vessels also have been injured, and they continue to leak. And remember that this pathophysiology that I show you here applies very well to other areas in neurology, like stroke, demyelination, hypoxia, and so forth. This is one of the models that we have developed at Boston University with Lee Goldstein. It has to, in this case, it's just trying to mimic exactly what happened in American football. And as you can see in the right lower part, you see the head of the mouse is being heated with a protection, trying to emulate the helmet. There are videos on this in which you can see how the impact on the mouse can make you ataxic, and then you cannot even maintain the equilibrium. Exactly what happens in boxing when somebody has been hit enough on the head. Now, this is the same picture, but with another way to look at the same data. As you can see, there are ions that go up, potassium, calcium. You see that the glucose has a bimodal behavior. This will go back to that later on the talk. The glutamate at the beginning, the cause of seizures. And in blue, you see that there is vasoconstriction, therefore less blood to the brain. And when you have that, you have less oxygen and less glucose. And so in a matter of way, the protective mechanisms can also, just like in a stroke, can act in detriment of the patient. Now, you have probably been familiar with what happened in England recently. They banned the heading of the soccer ball by players younger than 12 years of age. And this follows something that had happened in the US for many years, I would say at least 5 years, in which the same was done. And in Canada, in which this was not only for soccer, but also for hockey, and of course for American football. Now, why 12? Why not 10 or 15? And it is actually an arbitrary age. However, the science behind it is that several of the main developmental synapses grow, networking of the brain, increasing the complexity. They finish by the age of 12. But as you know, demyelination only, myelination only, is being said that it completes it up to 25. So there is some arbitrary decisions in here. It's not perfect, but when you think about it, that in the past, a 7-year-old was allowed to play tackle football, so going head to head, that you think that this is probably a good beginning. But again, not perfect by any means. Now, this is an interesting disorder because you see, you never talk about, when you talk about other entities in medicine, you don't talk that there is a need for a silent evaluation, right? So the most important thing here will be that the person that is injured being evaluated in the place that is occurs. However, this is not always possible because coaches are not doctors or physicians or paramedics in the case that this is in a sport. However, that will be optimum in certain sports. If you watch the Euro Cup or the America's Cup recently, you notice that they start to having neutral doctors, equipment, teams prepare for these, and there are certain protocols that are being applied. Not always perfect, but much better than in previous years. The evaluation in the emergency room is to make sure who needs imaging and who stays in the hospital. Obviously, those ones with progressive disease progressive symptoms need to be evaluated more carefully. And if they come to the pediatric office or concussion clinic, they obviously will benefit from, and I believe this with a little bit of a bias, if you're a neurologist, from a complete neurological exam. And some of the clinics offer also neurocognitive testing. Our clinic has a psychologist, a neuropsychologist, and several therapies and state-of-the-art rehab facility for the acute setting. And then there are others in the city for the chronic setting that we use for the player recovery or patient recovery. Now, at the silent evaluation, if you look at there is a form that is being used in sports called the SCAT, Sports Concussion Assessment Tool. Now it's version 6. This is free of copyright, so you can print it from the computer. It comes in English and I believe Spanish. I don't think there are still other translations for this. However, this is a form that recommends what you should do in the silent, in the moment, on the place of the player, if this is a sports player. There is a neuropsychologist whose last name is Maddock, who developed some questions to replace those of the typical mental status examination, realizing that if you ask a player, an athlete, about who is the president of Australia or who is the premier minister of the UK or France, it might be difficult for them to remember. And so he developed these questions that are more related to the game, like what is the score, who scored last, where are we playing, which team are we playing against, and things like that. Currently, we're validating on a scale that it is a mirror of the Maddox, but it is a special only for soccer. This is working with the Uruguayan Soccer Association and the South American Professional Association. And it's important to document everything you do and make sure that you follow up if you are the one that is doing the silent evaluation. In the emergency room, we still use the Glasgow Coma score. It's important that you use the pediatric form as much as possible. There are some guidelines to the care of these patients by the trauma teams that are in place in the US. It's enforced that you're certified in a ATLS and the last 10 edition. You always need to rule out a potential spinal injury, importantly at the cervical level. Make sure that there is no progressive neurological symptoms or deterioration of the mental status. Make sure that there is no increased intracranial pressure. Always look for the triad of hypertension, slightly bradycardia. Make sure that you understand what that means, that when you examine children who have their own parameters for this, and then you will be making the right decisions. There is, would like to add in here that for imaging, we have become very concerned about radiation, and that we use now the PCARN scale that it is also being free. You can use it in your cell phones, and allows you to calculate about when exactly you should get imaging. This is to reduce unnecessary radiation for the risk of malignancies. Because in concussion, there are so many symptoms. There is now 23, including sweating, according to the last version of a SCAT-6. Then it is important to, at least in the first follow-up, if not in the emergency room, to get an idea of how many symptoms and a severity score that above age 13, it is marked up to 132. This allows you to be objective in what are the symptoms you're targeting, and it helps you with the evolution of the patient. One of the best tests in the first week, because of the sensitivity, is called the BEST test, balance error equivalent scoring system. You ask the patient to close their eyes, put the hands on the waist, and keep the balance. As you can see in A, you are supposed not to have any errors. On B, with one leg lifted, you can have up to 5 errors. And on C, double stance, you're allowed to have up to 3 errors. And by errors, I mean just loss of equilibrium, repositioning, anything that you on the visual view is different than the static, then it will be considered an error. You can mark that. Now we do have in the available in our clinic a computerized way to do a neuropsychology testing, because this is difficult to obtain in a regular terms unless you work in a very specialized area. This is you have to pay registration in the US to get access to this, and they will storage this material. But it's important because if somebody has had a baseline impact testing, and in New York, for instance, but gets injured in LA, if the doctor in LA has access, he can get access to the baseline impact testing and compare. And as you can see, there are several neuropsychological or intellectual functions that are being examined. It's not a perfect neuropsychology testing. It's not an intelligence testing. When you do it to your colleagues, you have to clarify that if you do that also to your athletes, because it is not something that measures intelligence, IQ. You have to remember words like this, and then several menus you have to say which were they, and designs like this, including the orientation. And then as you can see in yellow, this is the X and O's test. You see the 2 circles in yellow, and the X
When they are in yellow, it's easy to find where they are, but if they were in black, it's difficult to remember. These are couples that you need to remember, and it's very hard, right? Because there are 9 couples that you need to remember later on how they were established. And then you see on the left the baseline, so verbal memory, visual memory, processing speed, and reaction time. And then you see what happens after the injury. 6 days after, you see this patient was very affected, recovering by 2 weeks, and by the end of the 3rd week, as most people, as it happens in most situations, like 80% recover to the baseline. So is this pathophysiology help us understanding the symptoms? Well, yes, the ionic flux might be responsible, or the migraines. The altered neurotransmission might be responsible, or the slow reaction time, damage to the axons, impaired cognition and processing, like in dementia, and the mitochondrial damage, the vulnerability to explain second impact syndrome and swelling. Obviously, some neurons are sick and some die, and that's responsible for chronic problems. Now, when you talk about management, the first thing is education. The patient will need to have rest on the first 2 or 3 days, for sure. Be well hydrated, sleep is important, and education again. And education not only to the patient, but everybody involved. It is important to encourage aerobic exercise after day 3. In the past, it was believed that the solution was to keep these patients in the darkness and not doing anything, but actually that has shown to be detrimental. And obviously, there are restrictions in terms of how much to use the brain. So even if you play, especially with the screens these days, computers, pages, cell phones, TV, movies, that need to be restrained, in particular if it is causing a problem. And the same, obviously, with more advanced exercise. It is important to reassure the families to say that this has good prognosis, but they need to adhere to the recommendations and the treatment. It is important to communicate directly to the school or the athletic team in the case of sports, because if you don't do that, there's no guarantee that the patient will inform the athletic trainer about the recommendations, and the same for the school. It is important to keep this in mind, because if the patients force themselves as to take an exam or study or don't sleep, then the symptoms tend to linger for longer periods of time. Now, the message is good. About 80% of patients, according to this study, as you can see, no matter the severity, improve in 3 weeks. But it's not always mild, right? And so when you have a more severe type of traumatic brain injury and the patient it is unconscious and you admit to the hospital, these days it is almost like a gold standard. You need to put an EEG, because seizures can happen in immediate period, minutes, hours, days after the injury, because of what are the changes that I have described. But then also they can appear later on, weeks, months, even up to 15 years later. It is being recognized the possibility of developing late post-traumatic epilepsy. And that is because of the scarring, that the damage that have occurred in the brain with epileptogenic lesions. Now, it is important to put the EEGs on these patients that are unconscious, because seizures that are subclinical are common in the ICU in patients in coma. And in this study, for instance, like it was up to 39% for those ones have both clinical and subclinical. 14 patients, that's 16%, but 7% of the patients have only subclinical or electrical seizures. This in pediatrics is where the younger they are, and abusive trauma and bleed. This is on certain injuries we can see on MRI, like contusions in the frontal lobe and the temporal lobe, as shown on the left in the red arrows and the hyperintensities, or the black holes, the sequela of diffuse axonal injury. Now, as I said, we need to talk about glucose at the beginning. This is a PET scan. As you can see, there is a lot of activity, the yellow and the red, but after the injury, there is depression, the blues. And look how much time it passed before we can recover the activity is similar than on the baseline. It's almost like a year later. So that means that the glucose metabolism suffered a significant impact after a head injury, even if this was regardless of the Glasgow score that occurred in these patients. This is the tensor imaging, diffusion tensor imaging. It measures how well the water moves in the brain, and the more severe symptoms you have, the more alterations on fractional anisotropy you have, which is the way that we measure diffusion in the brain. And you can see there is in this study damage on this, particularly on the corpus callosum in this series. Now, if I show you the brain of a football player on the left, compared to the control study, you will notice clearly that several tracts are missing. So, for instance, in the frontoparietal area, if you compare the green to the orange, it is clearly the orange has less population. And then what is striking, though, is that the entire tract going to the temporal lobe has disappeared. This study of Shenton is very important because it helps us understand the prevalence of the neuropsychiatric symptoms in these patients. Now, imaging has evolved, and so we have ability, we use certain type of imaging to identify certain changes, but this is not the standard. So you will need to use a PET or an spectroscopy to evaluate for mitochondrial damage, or diffusion tensor imaging or magnetoencephalography to assess axons, or functional MRI to assess the way that neurons are talking to each other, or modern types of MRI 3 Tesla, and nowadays at Mass General we even have a 7 Tesla. When we see a patient with this, we always like to see how bad the situation it is. So we want to know how long this patient is going to take to recover. So we like to see how many symptoms and what is the score. Was the loss of consciousness prolonged, as this patient remembers what happened before or after, and if he had had injuries before, and how long it took for him to recover in the past. If the patient had ADHD, a learning disorder, migraines, and more importantly, psychology, then we're talking about probably persistent long periods of recovery. Now, why is that we don't like the patients to have an injury as they are healing from the first one? And we would like to wait until they're asymptomatic before they get hit again if they decided to go back to sports, if possible. So the idea is this: they get injured, they have symptoms, they are not functioning well. On the first day, there are changes on behavior and metabolism. And if you wait until in this case, the mice were asymptomatic, and you do it again, same type of injury, in this experiment, you see that the curves are exactly the same. But what happens if you hit the mice before they have completed the recovery process? You can see that the symptoms are lasting longer. So these are the basis upon which we do not recommend contact sports for patients that have not fully recovered. Now, if you went to the gym today in the morning, you notice you might have feel very happy after the 20-minute running or jogging, or whatever you do. In part, it is because there is an increase of a brain derivative neurotrophic factor. When you send an athlete or a patient with concussion too early, this is the curve, and when you set it too late, this is the curve. So it is important to try to find what is the right timing for patients, what is the right timing to go back, not too early, not too late, but certainly aerobic exercise no later than day 3 if possible for the athlete. Now, it is being said that the IQ gene, it is on the AMPA receptors. It has 2 components, and after injury, it has been proven that the NR2A protein goes down. What will be important if we have something that can replenish the NR2A, and so this group from California check what happens in the activity in patients that have suffered traumatic brain injuries. You compare the lower part with the upper part, you see a lot of activity in the first row when compared to the ones that you see on the lower part of the pictures. But what about if you use something like dicyclorine, which is an NMDAR coagonist that binds on the gliadin site. It is FDA-approved agent because we use for tuberculosis. I'm sure you guys have used that too. And then you can recover. And initially, it worked well on the laboratory. When this was used in humans, it didn't work so well. So until we find a treatment like for a strep, a patient comes to the ER, you do a sore throat, you give penicillin, and in 10 days, that's it. Until we find that, something that will prevent the tau to move around, for instance, then we still need to wait until the patient recovers cognitively, physically, and neurocognitively before they go gradually to the sport. You need to verify they move slowly from one phase to the other, from increasing the heart rate to the drills. And to be honest, and this is difficult these days because there are so many pressures for athletes, parents, coaches, and teachers. You need to be very careful not to say what happens at the professional arena. And this is the case of Eric Pelly, an 18-year-old young man. You don't need to be old. And he was a fantastic player of all kinds, American football, hockey, was hired already by professional teams, but tend to hide the injuries before telling the parents. And so he had several concussions. The last one, when he came from Pennsylvania after one game, he went to the emergency room. The emergency room physician told him that no contact sports, but because he didn't say no weightlifting, he went to the gym, did weightlifting, and then developed what is called second impact syndrome, progressive herniation death, as you can see on the right upper corner. He did donate the brain to the brain bank that is being sustained by Boston University again at the Veterans Hospital here in Boston. It's called the Brain Bank, where most of the athletes that die have donated brains to be studied from different sports. And we are finding that regardless of the age, we start finding these deposits, and reason why it is considered a potential pathophysiology of CTE. So in conclusion, acute pathophysiology is related to early symptoms and shows recovery over a set time course. Many pathophysiological changes coming out detected by advanced neuroimaging. There are still elements of the diagnosis and treatment that require more evidence. And yes, you can develop your own concussion program no matter where you are, provided that you have the interest and the institutional support. And with that, thank you very much for this invitation, and open for questions when the time comes. And I'm happy to join for the remaining of the program. These are my colleagues from the pediatric brain injury program that we have here at BU. Obviously, there are different areas, right? Research, very important. Rehab, my colleagues, my fellows, the psychologists, the neuropsychologists. This is the group in which we work together. On the left, Bob Stearns from the Chronic Traumatic Encephalopathy Program. On the center, the Brain Bank, Dr. Bob Cantu, Anne McKee. And on the right, the animal model, the basic science part, Lee Goldstein, and all of these teams, fortunately, in our university. In terms of resources, I recommend you the one from the Center for Disease Control. It is a program called Heads Up. And then this program, after watching a video for physicians, or you can also ask coaches or teachers or parents involved to take. There are different levels of training. After watching a video, coaches in the US are mandatorily, they need to pass these tests every 2 years. And so they are certified in recognizing the concussion. They are not supposed to diagnose. In the US, in particular in Massachusetts, there is a law that says that if you have, if the coach suspect that somebody has had an injury, need to be removed from the field and will not go back on the same game, something that causes more than one problem on the silence, but prevents brain to be damaged. And with that, I think, thank you very much. I think this is a copy of my last ticket to Delhi, and where I had a lot of fun. And as you can see, it is very important for me to share with you this scientific information. And thank you.
Thank you, Dr. Elsie. Before Dr. Arvinder continues, you please book your ticket from next year, 17th to 20th September 2025 for the AOCCN. So we have already blocked you for that. Arvinder, please.
Yes,
Thank you
ma'am.
very much. Thank you.
So, there are a few questions in the chat box, and we can.
Arvinder, before that, after this excellent talk by Dr. Elsie, we'll have comments from the experts, Dr. Biju, Dr. Hassan, and Dr. Deepak, and then you take the questions.
So I would request all the experts, Dr. Hassan Tekul, if you can give your expert comments.
Oh, thank you so much. I say thank you very much. Fantastic presentation. It was really informative talk about the traumatic brain injury. You have clearly mentioned about the majority of the traumatic brain injury are the mild form. As you know, in the emergency room, we do computerized tomography and the conventional magnetic resonance imaging studies. Then we accept the patient in the ward and sometimes in the intensive care unit. So we try to classify the cases based on the neuroradiologic images. But if we don't use the new magnetic resonance imaging modalities, you mentioned that SWMRI and diffusion tensor imaging, we missed a lot of microbleeding in the different areas of the brain in the mild case. So we classified wrongly the cases to define the long-term outcome. So I think in the future we will use more new neuroimaging modalities to define and classify to the cases mild, moderate, and severe. So we have to be changed the Adams classifications using the new modalities, especially, you know, there is a brain injury in the area. So there is a new structure, new connectomes. Then we have to be clearly define the neuroanatomy using the new neuroimaging modalities. What do you think in the futures? Do you think we use new classification for the neuroanatomy classification for the mild cases also? Recently, we have just finished a study with 30 cases of the traumatic brain injury. Most of the cases are 85% are the moderate to severe, but we missed a lot of mild cases when we use the emergency room conventional MRI and without SWMR and then diffusion tensor imaging. Do you think in the future we are going to use more these modalities to make a correct classification for the outcome?
So, Hassan, I completely agree with you. I think one of the problems have been the understanding of the microscopic to the macroscopic world. And we tend to be focusing on one aspect, different groups of research, I mean. And so far, there has not been an effort to put all of these together. Traditionally, the old way of classification is to use the Glasgow. 14, 15 will be mild. Anything between 8 and 13 will be moderate, and anything below 8 will be severe. But as you said, there are within these groups, not everybody has the same prognosis. And so the question it is, what will be the best method to define or to classify the prognosis for that? There is a recent study about connectomes. I don't know if you're familiar. This was published in, let's see, by a group of run by Tyler Good. And this group, it's basically saying what you're saying, but trying to promote that we should use the connectomes in the future
as the best way to decide which one goes to different prognosis. However, when I asked my group to look at this, to look whether this was possible, my group of neurophysicists in the hospital could not find differences between even mild to severe. And so we need to, because these things are new, we also need to take a little bit of take them with a little bit of grain of salt, because yes, there might be, but we need to improve our techniques.
Thank you.
Deepak sir, you could.
Hi, first of all, thank you so much, Dr. Shefali, for making me a part of this presentation. And thank you, Elsie. I've read a couple of your papers on concussion, and it was quite enlightening for me to listen to you. And I really like your idea about having a concussion program, because I personally believe most of the things which are happening in the concussion, because I'm a pediatric neurosurgeon, so I deal with children all the time. Unfortunately, we admit only severe traumatic brain injury patients in our center. In fact, Dr. Shefali Gulati and us, we had done a study at AIIMS Trauma Center. I think we had analyzed something like over 5,000 children. And again, we were admitting majority of the children were severe TBI. We had 65% incidence. Now, my question to you is, most of the things we are talking about in concussion, they're actually the lab experiments. Most of them have been, if you talk about the higher studies, you talk about those functional studies which you talked about. My understanding is most of the children with the concussion, they're actually missed. Because we all understand, I as a neurosurgeon understand that it's more of a functional injury and less of a structural injury. Yes, of course, we have been doing a lot of connectomic study, mainly for the brain tumors and other things in a routine neurosurgical practice. Somehow, we don't have that clinical data on the children affected with the concussion, at least not in India, to my understanding. And I really look forward to your comments. Do you see concussion injury in child abuse cases in your nation? I mean, what is the incidence of concussion and how exactly do you go on managing those cases?
Yeah, so thank you, Dr. Gupta, for the question. We do see child abuse in the US. As you saw in the picture, in the initial picture, you saw that one of the peaks is in the infant group. And you would imagine, why is that, right? Well, first of all, because they have less myelination, they are less mature in terms of the motor skills. They also are more vulnerable, and that is because of the, unfortunately, child abuse. And on this panel, we have an expert that ran an experiment during the pandemic, Dr. Bijou, who found out that there was actually a higher incidence during the pandemic in this group. Not only that was already high enough, but even were higher during those days that the parents were at home concentrating. So it is a serious problem, and we do manage this through a child protection team. There is a protocol because there are mimickers, and in the US, it's a very litigious society, and is taking this very serious. It's not like everybody, even if we know that somebody had bilateral subdural hematomas and the typical retinal hemorrhages, we immediately claim that. There is an investigation. There is a group called Child Protection Team, and only when they say that this is the case, then the social workers intervene and separate the child from the family. And that is protected by the state. Now, to the first point of your question was whether we are missing some of no, we're missing a lot. And not only in India, we're missing everywhere. I tried to write a paper on pediatric global health for one of our meetings with Bijou, and it was very hard to find the paper. I teamed for this with a group from Hong Kong. And again, it was regardless, I think the exceptions are clearly New Zealand, Australia, Canada, and the US, and it's so few that it's very easy to mention in this conversation. It is being recognized that the majority don't hit the hospital because most of the patients will say, no, I don't want to go, I'm feeling okay. And even in the best, let's say, resourceful societies, the parents will prefer to go see the pediatrician, or in other societies called the uncle or the grandpa who is a physician and works in this hospital, and so on. So in the US, we have a void that the law prohibits that any certificate be written by anyone related to the family, but also that is not certified in traumatic brain injury.
Thank you.
There was a question on the chat I would like to address briefly, just so it's not late standing there.
Dr. Elsie, no, this is not late, but Biju has been silent. So after Biju has opened his unmute, and then you can answer
No,
the
I was
question.
also,
Biju has
I
been
was
totally
also,
silent. Yeah.
I was, no, I was also, no, I was listening. It's interesting. I was also looking at the chat. Now, thanks, Olsey. Always fantastic to listen to you. And you know, you and Dr. Deepak made pertinent points, because I mean, there's no doubt that there is enough evidence now that TBI in any shape or form is bad, be it mild, moderate, or severe. And for that, we need that advocacy. Particularly, it's quite timely that you are addressing a particular region where it is a pressing problem. It's sure to be an even larger problem in coming years with the increasing traffic and everything. But for that advocacy to happen, you need to increase the awareness. And in order to increase the awareness, we need the literature to support it. And that's where things, really fall apart, because these children don't come to hospitals and you can't really get them. I even thought about perhaps there's a way of getting them from schools, to go back and see how many children have had an absence, and when they had reported that they were absent because he had a head injury the previous day or something, and then capture these children and try and address them. Because even when we did the kids head injury study, looking at the long-term cognitive and psychological sequelae, we could only get moderate to severe head injuries, because those are the only population that we can capture at a regional center. So the mild always get missed, which is a major problem. And also, as Dr. Hassan was suggesting, how do we decide whether somebody is mild? Because there are no biomarkers. You could do for example, you could do a CRP and say oh, CRP is only slightly raised, it's just a mild infection, as opposed to the CRP, it's way 100, it's a serious infection. But we don't have a biomarker. So my question to you is, obviously prevention is important. Prevention, it should start with prevention, starting with proper traffic rules and advocating for people to wear helmets and safe practices in sports, at schools, etc. But in the absence of all those, what about, we've briefly talked about this, I think, in one of our discussions, I think a few months ago. What about preemptive technologies, where predictive algorithms can be used to anticipate a collision, and then somehow institute technologies? I might ask Dr. Deepak's advice on this as well. There are for example, I had a chance meeting with Dr. Vince Bryan, emeritus neurosurgeon, who's an innovator, and he was waxing eloquently on the system where the player wears a transceiver or a stimulator. The ball contains a embedded transceiver, and then when it comes closer, suddenly the system recognizes that there is an impending collision, and it actually stimulates the physiology to institute protective. Now the question is like, what are the protective physiological mechanisms that the system can institute in order to prevent? Now, Dr. Deepak, I might want you to enlighten us on this in terms of the venous physiology of the brain when a mild trauma happens. Now, when speaking to Vince Bryan, he was saying that the venous pressure actually goes high. In fact, the veins get engorged, because my understanding is that they don't have much smooth muscle, the brain venous system, and they get engorged. They engorge in a natural, in intrinsic mechanism to cushion the brain, as if like to prevent them from further damage. And Vince was saying like this sort of protective, I mean, in fact, they have tried to get a patent for this. And the reason why I met him was like he was on a investment search, and then we had a meeting. So the player wears jacket with a stimulator, with a receiver, and when the impending collision is detected, the mechanism encourages the person to do like a Valsalva type maneuver, which then increases the venous pressure, which sort of like gives a cushioning effect to the brain. Very fancy, very, very fancy thing. But my point was like, preemptive technologies and predictive software algorithms can perhaps be used, or we might see them in the future. And I think you probably are aware of like few other similar technologies out there, isn't it? So that was my question number one. Perhaps before I forget, I could ask the question number two as well. So that was one. The second thing was biomarkers and the role of BDNF as a biomarker. And because, like when it comes to rehabilitating these children, you take two children from two socioeconomic backgrounds with a similar mild injury, and even if we adjust for the pre-injury characteristics, the children from lower socioeconomic status do badly in terms of rehabilitation. And it's been thought to be due to the genetic polymorphisms of the genes, particularly BDNF. And I think that I remembered that because there was a question, something related to that, as genetic factor can change the prognosis of the result of TBI in different patients. So the BDNF polymorphisms. So those are my two questions: preemptive technologies and BDNF.
So, as always, Biju, always innovative. So I would say that on the technology, what you just said is the future. It's some type of artificial intelligence, but we're still at the very beginning. I did a grand rounds at CHOP, Children's Hospital in Philadelphia, and I asked them to a very important group of research. I said, guys, I want to do work on autistic spectrum disorder, but they don't let me attach anything to the head. I want to measure the severity of the injuries that these patients are getting. They are non-verbal. So I'm very interested in knowing what's happening in people that are not talking. And they connect me with a couple of engineers, but the technology was not there. There's nothing that I can attach to an autistic spectrum disorder kid. So that brought the idea that you're bringing to this table. Can we measure this from outside? So working with a group of Chile, we found out that the videos in itself, using some technology, can detect direction, force of the impact, and obviously document the number of times. But again, it's not perfect, because I did tell you before that it's not only the hits, it's also rotational moves sometimes that trigger these symptoms. And so that way, that's a working in progress with a Chilean group that they find an engineer that was willing to develop this technology. But you all drive cars now that can tell you, oh, you're going too much on the left. Oh, you're going too much on the right. The car forces you to. So I don't see why in the future the soccer ball, for instance, if you want to go some sport that I'm familiar with, might have something that actually deviate the ball before hitting the head of somebody after a certain degree of a speed. Now, this is like a very far away in the future, right? But everything starts like this. And to the second point, definitely genetics, it is playing a role in this, like in everything. I usually ask my patients, is there anybody else in your house, in your family, that had a traumatic brain injury? And my students and my residents look at me like, why is that important? And it is important because there is a gene that tells me how is that some people are predisposed to have more symptoms after a head injury, just like in everything. And you also add another layer of genetics, which is the degree of the environment in which one was lived, as to make you more predisposed to have factors that prevent you to recover from any event, not to say a traumatic brain injury. It is very well known that a female teenager, poor and depressed, do much worse than any of the other groups. And so if you do that forever, right? If you do it over time, then no question that there is an influence on the genetics. And this is not only purely esoteric and psychological. This is expression of proteins that stop doing what they were doing before and they are acting differently. And there is a lot of good work on this, actually. It's not that esoteric as the first one, but it's happening. Now, do you mind if I go through the questions on the chart just so?
Maybe just, if you ask Dr. Deepak for 1 second, whether he can enlighten us on whether there are, like what I was hinting at was venous changes in injury. This is
yeah.
long before all the Cushing's response and everything happens, in mild injuries.
So, in my
Can I
hospital.
ask
Yes, please, go ahead.
Can I ask you a basic question? What Biju was asking was high tech and which will be there, obviously will require a lot of data. One thing is, can you not, you have so much of experience, cannot you initiate the lead, take the lead and make some AI driven thing, because you need a lot of data to, be able to get an algorithm. That is one. But the other thing is, there are some patients, the kids have been doing those headshots, So now whether you completely discourage those. Number two, that we have these autism patients. Some of them have those self-harming behaviors. They'll go on hitting their head on the wall, right? So, have you seen head injury related to that? Many more damage. It's likely to. It can cause. And lastly, I know that causes serious brain injury. But do you really see shaken baby syndrome that much? In the US as well?
So we do. Let's just start from the third one to the first one. We do see a lot of child abuse, and it is an important part of our practice. And unfortunately, it doesn't go down on the last time that we look at these data. And the second question was, can you remind me
the autism patients who are going to be self-harming, they hit their head advance against the wall, right?
No question. We always have this autistic patient that arrives to the office hitting on the head or with symptoms that we do not understand. And they are temporary, right? We all have had. They are non-verbal, but there is no question that in some of them hit the head a lot of times. There is no question that cannot be asymptomatic. If you think about it, just mimicking at them for 30 seconds, it could be very tiresome to see the hitting, right? The repetition. Could you imagine if that is for an extended period of time? No question. And the first one, could you please?
Whether you can take the initiative, because you have so much of experience to develop a AI-generated thing.
We do have a group, Lee Goldstein, in our hospital. It is looking into the dynamics of the blood flow and the leakage, and how are things that we can do to prevent this, so avoid sequela long term. But to address Biju's point, there are ways to measure that from the outside, like a near infrared spectroscopy developed by Adre Duplessis at Children's to look at problems of hypoxic ischemic encephalopathy. And so can we look at these in patients that have severe trauma? Yes. In patients that have less severe trauma, might be a little bit technically difficult at the moment, but I don't think that is impossible. However, I do think that we are very far away yet from something like artificial intelligence that will just feel that there is a change to decrease or change the impact of the patient is receiving. But you might agree with that.
few questions in the chat.
There's a good point on, like the autistic children repeatedly. About 10, 15 years ago, there was a paper which suggested that, like in army and other places, sometimes you are exposed to little injuries in order to make you more resilient. So like a small amount of poison you give in order to make you immune to the poison, or like giving you small amounts of electricity, then you can tolerate higher shocks. So sometimes you often see these goats, rams ramming their head against each other, and then you wonder, like, they never get any head injury after that. So there you go.
Remember
Next.
that one of the symptoms in autism is decreased sensibility to pain. So
Yeah,
there you go.
true, exactly. True. Dr. Deepak, yeah.
Hassan also has the hand.
You're muted.
Yeah.
Sorry. I think it's high time from all the discussion I'm hearing that there is an urgent unmet need to start looking after these babies affected with the concussion. I'm talking about the school children primarily. In my practice, we have 37-bedded neurotrauma dedicated ICU. At a single point of time, we have something like 8 to 10 children with the severe traumatic brain injury. However, there are no admissions of concussed because it often gets unnoticed. And I think that's a much more broader and wider kind of a ignored population of our society. And because I'm a part of this webinar, I would ask Dr. Shefali to take the lead and get in touch with you and make something like a concussion program to begin with. It could be in the institute and then spread it to the rest of the country. And it is really, really needed. In fact, I'm in the executive committee of Neurological Society of India. And we initiated at AIMS, and then we spread it to the rest of the nation and to the rest of the world now as a part of WFNS, something like a Safe Balcony, Safe Child campaign. Maybe I would request Dr. Shefali.
No, it'll come. We have to organize after this, before the cases, it'll come. Yes, yeah. Hassan will say something and then Elsie has to answer the questions, and we have 2 quick cases.
Thank you, Shefali. Yeah, a short comment on that. When we are talking about the new modalities, new technologies for the traumatic brain injury, we are neglecting and then we are underestimating the old technology, EEG monitoring. I think we have to be used extensively for prognostic, for and also classification. For a short time and a long-term EEG monitoring is important. The best prognostic parameters when we compare the neuroimaging modality, the best parameter is the EEG abnormalities. When we look at the 3rd month's follow-up and then 1-year-old age after the traumatic brain injury, I think we have to be used extensively EEG monitoring for these kids. Also, I would like to say on that.
So thank you, Hassan. I think one of the best advances in neurocritical care has been the use of EEG in patients with traumatic brain injury that appear conscious with loss of consciousness to the hospital. In the past, this was only for the patients with seizures or epileptic seizures, but in these days, I think every unit likes to put the leads on, because as you can see, otherwise you will be missing, and then the patient is not waking up and nobody knows why the patient is not waking up. The patient has been in status for a week, right? We all have seen those patients. And so this has been a major change. The multimodal monitoring is the other one. More units are trying to put all of these data together and being analyzed together. So physicians in the ICU have I always wonder, how many times you might miss an abnormality with so many numbers in front of you. Now you have computers that will summarize the data to you. And that's also going on into neurocritical care. And I think a little bit of the use on hypothermia in patients with severe TBI, or this is more in adults, but selective cases in pediatrics are the three major advances in neurocritical care the last few
Yeah,
years.
thank you, Elsie.
LCR paper is in Journal of Child Neurology in 2020 December, which Deepak was mentioning when we had reviewed 15,000 head injury patients, out of which 4,833 were pediatric. So that was there. It was a retrospective data on that. So we have a lot of burden actually. Yeah. And want to answer the queries? Arvinder, want to read it out? The questions?
Yes, ma'am. Most of the queries have been answered already. And there are few questions do asphyxia and brain trauma have the same effect on the brain? So
So this is very important, okay, one must say. Once I tell this to my students, if you learn the pathophysiology of this, it's not exactly the same, but a lot of the mechanisms are similar with the stroke and hypoxic ischemic injury, which raise the question also in how few studies are in neurotransmitters and another molecular players when it comes to traumatic brain injury compared to what we do for hypoxic ischemic injury. And the sequelas could be the same depending on what age this happened and what were the circumstances. The brain is only one, has the same regions. If the same regions are affected, you're going to see a lot of similarities. But the pathophysiology is the one that you need to remember because it's exactly the same. Is the instead of the hammer or the rotation, you remove the oxygen and then you have it.
And one more question is directed to you, that any suspected case of traumatic brain injury came to your hospital with SDH and that finally turned out to be glutaric aciduria type 1?
No, that happens. Usually it's child abuse, the typical cases. But again, remember that in the US, we do a screen for organic acidemas at birth. And so it will be unusual for somebody that was born in the US that this was not previously diagnosed. The presentation of glutaric aciduria, though, it is not only just bleeding. It is usually a little kid who has global developmental delay, a very large head, and also has very distinctive movement disorders characterized by significant dystonia, hemivalismus, and a variety of conjunction and regression over the past over months. So a little bit different. And then you do the MRI and you have your diagnosis supported by the widening of the sylvian fissure.
Thank you so much. Actually, can we take your 10 more minutes, Dr. Elsie? Because actually we wind up by 9:30, but there are two brief cases, 5 minutes each. Can we have that? And if your permission is there, and while the presenters load, I just want to tell that we have the 70th Asian Oceanian Child Congress in Yashabhumi next year, 20th September 2025. Please block your dates. And next also we have a conference on, we have a CME on 21st and 22nd of September on autism spectrum disorders, which details will be shared. And this is what, Dr. Deepak was talking about for making the safe balcony net, because we have so many head injuries, right? Of falls from the roof and terrace.
Thank you.
Yeah, I think all of us, the pediatricians will have a major role to play, whenever the parents come with some other issues. This is something which needs to be talked about. It's so disheartening to see children dying. Like we know that over 60% of such children, they actually die on the spot. And majority of them, they end up getting either barbiturate coma or, getting subjected to decompressive connectomies by us. So I would urge at this platform to all the pediatricians sitting here to please spread this message to your centers, to your cities, about safe balconies, safe child. And we are talking something which started in USA, I think in 1976, this campaign was initiated in USA, Kids Cannot Fly. And after that, I think there was almost 96% reduction in the incidence of fall from windows injury in the children. But unfortunately, in my country, and the adjacent nations, children keep on falling and they keep on dying. Very basic things, we just tell them, put a net to prevent a death. The balcony height should be more than 1 meter. The distance between the balustrade should be less than 3 inches. And balcony should not be used as a playing area. That is the commonest mistake which parents do when they leave their children unattended. And we always tell them, keep a kind of the balcony door locked. At our trauma center, what we have done, any child who comes to me with the head injury and I operate, and before discharge, I tell the family to send me the place where the child actually fell from. I have all the pictures, and there was no balcony. I ensure that they build up the balcony before the child is discharged, so that the child does not fall again. And I would request all of you to please spread this message to your cities. Thank you.
Thank you, Dr.
Also, and
Gupta.
also, Dr. Deepak, when you look at the long-term sequelae, or when you look at the mechanism of injury and the relation to long-term sequelae, if you exclude the traumatic child abuse cases, fall from height is the most significant factor, even more serious than the road traffic RTA passenger accidents. Yeah.
Thank you.
I just wanted to
Absolutely, and
add one comment. It's interesting, Dr. Shefali, if you allow me. This is critical. In the US, we have guidelines and recommendations for lots of things, right? And anticipatory guidance. And I look at this, 500 people die falling out of the bed, right? So how many times you consult about the type of bed that the patient is sleeping or where they are sleeping, especially those bunk beds?
Yeah.
500 kids. So if you're talking about prevention, something as similar as that.
And
Lots
Dr.
to do.
Elsie also helmets, in actually in the West, even, in all the cartoon characters have helmets, even the animals in the cartoon characters have helmets. Here, I don't know, that's a problem. So in addition to the safe balconies, the helmets, this was that autism workshop I was talking to you about. And I think we'll just have the sharing of the 2 cases briefly, 5 minutes each. Mahesh, your student, and Lokesh Saini, your student, please. 5 minutes each, it's across the time. We had a very enriching discussion. That's why we crossed time. So we'll just give them 5 minutes each. There, Mahesh,
Yeah.
your student. Yeah. Yeah,
So,
please, yeah.
First presenter. And
You know
she's-
what, Dr. Elsie, I really like their titles, every time they come with such exotic and interesting titles all along. We've had always cases and everybody gets with nice titles.
Can I start, ma'am?
Yeah.
Please, your 30 seconds have gone, yeah?
Good evening, everyone. I'm Dr. Tanuja, doing my pediatric neurology residency in JNMC Medical College under the guidance of Dr. Mahesh Kamte, sir. Today, we are presenting the case of a child with a not so hard fall. So we had a 9-year-old male child who had a fall while walking. So he slipped and hit the back of his head against the wall. Following this, there was transient confusion for about 15 to 20 minutes. There was no history of nausea, vomiting, loss of consciousness, or any ENT bleed. GCS was 14/15. CT head was done, which was normal. So this is fitting into the mild traumatic brain injury criteria. As told before, traumatic brain injury, mild is if GCS is 13 to 15. The child had headache, and initially it was thought to be because of the local pain. But this headache persisted for over a week, and that time MRI was also done, which was normal. When he presented to us, he had headache going on and off for about 4 months. This was about 2 to 3 times per day, and it was bilateral in the forehead region, lasting for about 2 to 3 hours. The intensity of pain was higher in the first 1.5 months. There was no history of associated nausea, vomiting, or worsening noted on exposure to light or sound. This was not affecting his activities of daily living, sleep, or play. He continued to have good scholastic performance, and there was no history of any missed school days. There was no history of fever, cough, or cold. Occasionally, he would use naproxen for the headache, which would subside. There was no history of recurrent headache in the past and no family history of headache. Examination was normal. So we thought of persistent post-traumatic headache, TTH type. He was asked to maintain a headache diary, and lifestyle modifications were advised. If he had persistent increased in frequency of headache or intensity of pain, we thought of starting amitriptyline. However, after about 2 months, the frequency and the intensity reduced, so we did not start amitriptyline. Headache after trauma can be of 2 types: acute if it is less than 3 months, and persistent if it is more than 3 months. this headache can be either due to mild or moderate to severe traumatic brain injury. We all know that post-traumatic headache is a common symptom after TBI. It is considered if it is starting within 7 days after trauma or after regaining consciousness or recovering the ability to sense and report pain. ICHD-3 defines it as a secondary headache disorder that develops or a primary headache disorder that becomes chronic or is made significantly worse in close temporal relation to a TBI. It is very common, as discussed before. Some studies have also reported that post-traumatic headache is more frequent after mild traumatic brain injury as compared to moderate or severe TBI. The risk factors for chronic or persistent post-traumatic headache include female sex, younger age, presence of headache at the emergency room, or presence of CT abnormalities. This post-traumatic headache can resemble any of the primary headaches like migraine or TTH. And it is important to note this because the management is also in accordance with the characteristics that it resembles. A predisposition to a primary headache makes it more likely that the child develops a post-traumatic headache. And there are multiple factors in play. It is interesting to note that there was no difference in the rate of persistent post-traumatic headache at 3 months, whether we treated them with NSAIDs or triptans in the initial 3 months. As told earlier, though traumatic brain injury is twice more common in males compared to females, post-traumatic headache is more common in females compared to males. And the incidence is more in the first 3 months. It reduces in the first 3 months and then sort of stabilizes till the next 12 months. Multiple factors can be in play due to shortage of time. I'm not going into this. And multiple sites or areas of headache can be present. And this can be of many types like TTH, migraine, cluster-like, or cervicogenic-like. Regardless of the subtype, the pain intensity reduces with time in majority of the cases. And if there is any feeling of depression, fatigue, sleep disturbance, vision problems, neck pain, or mobility, they can indicate that they may have a persistent or chronic headache. Medication overuse headache should also be kept in mind because these children are prone to increased use of analgesics. In these cases, after discontinuation of the analgesic, they may notice improvement. So to conclude, post-traumatic headache is a common entity and it is important to treat for better quality of life. It can present as migraine type or tension type headache commonly. Predisposition to headache is a risk factor for developing persistent post-traumatic headache. It is a disabling sequelae with unclear pathophysiology and there is lack of specific treatment. Treatment is usually with analgesics and lifestyle modifications and in accordance to the type of headache it mimics, that is migraine type or tension headache type. There is a need for prophylactic therapy when it is chronic, affecting daily life or affecting the quality of life. Thank you.
Mahesh?
This child had a very minor head injury form of shutting his head to the wall. And he had daily headaches which continued beyond 1 week of the fall. Parents were very worried and because the CT scan was normal and even the MRI was normal, it was very difficult to convince the parents that it was due to that minor head injury. However, with painkillers and proper advice for lifestyle modification, the headache reduced in frequency over a period of 2 months. And after about 6 months, child was off medication. So we had difficulty in convincing the parents about the cause of these headaches. I want comments from the experts regarding the management and counseling.
May I, Shefali?
Please.
No,
So thanks, Anuja. Thanks, Anuja, for a very nice case. You'll get the certificate by mail. Sorry.
There's only one question I wanted to ask. This was a 9-year-old child who had a spontaneous fall. So, as a standard practice, children having a spontaneous fall, we always evaluate the craniovertebral junction in the cervical spine. I'm not sure if the MRI, the brain only was done, because at the end of the day, we need to find out what was the cause of the fall. That needs to be looked into.
He had slipped, so he slipped. He had slipped and then he had hurt his.
Dr. Elsie? Dr. Biju?
Yes, thank you. Tanuja was a great case. I like the presentation. I just have one comment. First of all, about when somebody falls, it's important to document how, because tripping, it's a good cause, but you can also fall because of other reasons. An arrhythmia, a seizure, a syncope, low glucose, drugs, and it's you don't want to miss that. So it's important to us and document very well that. Sometimes it's difficult, and then you have to decide when to expand your workup. And the other comment that I have, I like the amitriptyline a lot. Like Phenychel, I think is the best drug for prophylaxis headaches, despite what the New England Journal article of 2016 said. However, in the acute setting, if you read the side effects of amitriptyline, are exactly the symptoms of concussion. And I wonder whether you as a physician will feel comfortable giving something to a patient that will exacerbate and make what they already have worse. And so I try to avoid at the very beginning. In this case, I agree. I would have done the same. But at the beginning, I try to buy time with magnesium oxide or treating the sleep with melatonin and the lifestyle modifications. Because the patient was 9 years of age and you give amitriptyline, it's also important to document that there is no history of arrhythmias or in the family. And because of the age, only because of that, I might have ordered an EKG before prescribing the EKG. For a long time I did, for a long time I didn't do. And yesterday I had a patient in which said, something gave me a vibe that I needed to do an EKG. It turned out to be borderline prolonged QT. So you have to be careful with that.
Thank you.
Another thing also, like if in minor head injuries, if you feel that the sequelae, particularly like the post-traumatic headaches, are particularly more severe than you would anticipate, and if there are history of multiple episodes like that, then you should also think about ion channel genes, because CACNA1A mutations can some, but there would be history, like sometimes there would be history of like familial hemiplegic migraine or something. But if in any head injury, if you feel the sequelae is over and above that you would have expected, then also important to think about ion channel genes.
Okay, now we can proceed to the next case, and our next presenter is Dr. Kanda Kumar from AIIMS Jodhpur, and moderator is Dr. Lokesh Sani. So Dr. Kanda, you can share your screen.
Am I audible, sir?
So you have 5 minutes, and then we will discuss this case.
Sir, are my slides visible?
Yes.
Good evening, everyone. I'm Dr. Kanda Kumar, Senior Resident from the Department of Pediatrics in AIIMS Jodhpur. Today, I'll be presenting an interesting case, and the moderator is Dr. Lokesh Sani, sir. So today I have two cases, but I'll directly move on to the second case for the want of time, as the first case is an classical case of an trivial trauma stroke with melodic encephalopathy.
The audio is not very good. I'm not sure if others are experiencing the same.
No, Dr. Elsie, he was skipping the first case. He said he had two cases to present, so he's not presenting the first one because he has 5 minutes. We'll present the second one. Yes.
Yeah, thank you.
So coming directly to my second case, we had a 7-year-old boy who was pre-morbidly healthy with normal development, presented to us with fall while walking on a wet floor, sustained impact over the head, and there was history of loss of consciousness and 2 episodes of vomiting, which was projectile and non-bilious. But however, there was no history of any obvious external or no ENT bleed. There was no history of seizures, and there was no significant past history. So at presentation, the child was vitally stable and there was no hypertension. And on higher mental function, the child was minimally conscious with DCS of E3, V3, and M5. There was no cranial nerve abnormality. On motor examination, actually, this was after once the consciousness has slightly improved, the tone was variable. There was weakness of all 4 limbs, but however, there was some asymmetry. Weakness was more pronounced over the right side. Power was 2/5, and on left side it was 3/5. The child was able to do anti-gravity movements on the left side. DTRs were brisk, and there was dystonia, which is again more pronounced over the right side. There were no cerebellar meningeal signs. So first, we had done NCCT head. In this, we can see there are some calcifications of bilateral basal ganglia, and there is a hyperdensity over the left basal ganglia suggestive of hemorrhage with some surrounding edema. And in the second image, we can also see there is mineralization of the lenticular striate arteries. Next, MRI was done for the same patient, but this was done on day 2. So first, let us focus on the right basal ganglia. On the first image, this is an axial T2 image. We can see patchy hyperintensity over the lentiform nucleus. And in second image, there is diffusion restriction over the involved area. So in right side basal ganglia, we can see there is an acute infarct. On focusing on the left side, we can see a circular hypointense lesion over the basal ganglia with some surrounding rim of hyperintensity suggestive of edema, and these edemas restricting. And third image is SWI image, which is hypointense. So on left side, there is an acute hemorrhage with surrounding edema, and MRA is normal. So after imaging, we have mineralization of the bilateral basal ganglia, suggestive of mineralizing angiopathy with bilateral basal ganglia stroke with ischemic over the right side and hemorrhagic over the left side. So the patient was started on anti-rise ICP measures and osmotherapy was continued for 48 hours. And stroke workup was done as per the unit protocol, and it was normal. And the child was managed conservatively. Early rehabilitation was established. So at discharge, left side hemiparesis has completely resolved. However, the weakness on right side was persisting with right hemidystonia. The MRS at discharge was 3. On 6 months follow-up, hemiparesis has improved, but however, the child had some fine motor problems over the right hand with MRS of. A few words about mineralizing angiopathy of lenticular striate arteries. So in this, we have 2 questions. So why only lenticular striate arteries are involved and why toddlers are more affected? So the pathophysiology is lenticular striate arteries, they form an acute angle from the origin of main trunk of MCA M1, and they are more vulnerable to any sudden movement induced stretching. And in younger children, brain is more mobile, especially the supratentorial part, facilitating the stretching of these following and head trauma. However, the exact mechanism of mineralization is not clear. It is known to regress with age. So in this, this is the M1 segment of MCA. We can see the lenticular striate arteries. In this, the lateral part is more acute origin. And any vasospasm or mechanical disruption following a trauma or injury to the intima of the blood vessel leading to subsequent thrombosis or any occult dissection leading to hemorrhage can lead to stroke. So this entity was well known during the late 1980s.
I think you can leave that part, Britta. Kanda,
Yes,
you
ma'am.
can leave it. You can just give a take-home message, right?
Yes, ma'am.
Yeah,
So we
yeah,
have
yeah.
mineralizing angiopathy is associated with ischemic stroke, but our case had an atypical presentation. We found hemorrhagic, both ischemic and hemorrhagic stroke in our case. On literature review, we had found only one case report with a similar presentation. In this, we can see the bilateral basal ganglia calcification and hemorrhage over the left side. But the age of presentation of this case was 3 years, and our case was 7 years. So it's postulated that mineralizing angiopathy at later age group can present as an hemorrhagic stroke. I will skip this part. So it's known for many years. There are some points to ponder. What is the role of aspirin for secondary prevention? As if the child has trauma, again they are predisposed to stroke. And is there any role of steroid to reduce the edema in acute phase? So the take-home messages are stroke with mineralizing angiopathy accounts for 2 to 5% of oral pediatric stroke. It is a non-life-threatening condition, relatively good prognosis, even though it has ischemic type of stroke during this typical age group. It can present as an hemorrhagic stroke beyond 5 years of age.
Thank you, Kanda, for a wonderful presentation. Lokesh, quick comments. Stop sharing the screen.
So just it's a common entity. Like nowadays, we see a lot of strokes, trivial trauma strokes, but most of them are ischemic. So we have presented this case because there is a hemorrhage associated, and while reviewing the literature, we understood that older children can present with hemorrhage with the similar entity. So it was an interesting one, and we always have this query that aspirin should be given or not in this entity, because we did not find any preventive aspect of aspirin in this particular entity.
Thank you, Lokesh. I would request the Need just 1 second, Deepak. I'm just saying all of you, like Dr. LC, you and Biju, because Hassan had to go, will give comments on this case, plus they will take home message. Because we are anyway 18 minutes beyond time. So comment on this case, plus give your take home message for the entire presentation. Sorry, that's what I was saying. We will club it together. Thanks. Please go ahead.
So it's the artery of candelabra. Okay, the traumatic basal ganglia hematoma in the children pediatric age group is something not very uncommon. We see and I mean, I have at least 6 cases in this particular year. And these are the bayoneted shaped vessels. These are branches of lenticular striate, yes. But actually, this is a short horizontal segment, very peculiar abnormality we see in the children. So this is a particular vessel called artery of candelabra, which is responsible for this hematoma.
Take home message also for the entire presentation, Deepak. Take home message also, Deepak, for the entire presentation.
No, the
Take home
presentation
message,
was,
that's what.
the presentation was excellent, and this one entity one needs to keep it in mind. And most of these children, they actually have got some kind of hemiparesis, and they all. Right.
Deepak, the take home message for the entire TBI session.
Oh, we should have a concussion program for the India. This is a take-home message for sure. And safe balcony, safe child. Please spread it to everybody.
And also the helmet, helmet also, na, that also. And then Dr. Biju, then you, and then comes to our star attraction in the end, last message. Hassan had to leave for a case. Please, Biju.
This case is very, very interesting. I remember the case the pictures that you showed. I think that was Lokesh's patient from Rainbow. I remember we talking about a long time ago, and I think subsequently Amrita also had a series. I think Vinayan also spoke about this.
Biju, we also have a series. We also have a series.
Yeah, big
Lokesh
series.
had
So,
to write when he was our
but
resident. Now also he is not written till now.
interestingly, like it seems to be very common now. I don't know why these particular vessels get mineralized. I don't know. I don't know. Is it because, and it seems to be very common from that part, from the Asian side of the from that part of the world as well. I don't know whether it is because of incidence of infections. I don't know. But there
So,
seems to be increased mineralization. So very interesting. Now,
I have
because
read.
we see basal ganglia bleeds, but mostly it is AVM or something, but mineralizing angiopathies we don't see much. So that's it.
We
And
have
in
very
terms of
many Biju, and I think I'm telling publicly to Lokesh, he had to write when he was my resident. Now he's a boss there, but he should write all the series together now from India. Sorry,
I'll
please.
combine it.
And my closing statement, I completely agree. Like promoting education and advocacy is the key. And I think as representatives of AOCN and the Neurosurgical Society of India here, I think it's high time because it's going to be the #1 killer. There's no doubt about it. TBI, well, it is already is the #1 mortality and morbidity, and it's going to be #1. And India will have the #1 for that. So I think we have a moral duty as associations like AOCN and NSI to do something about this. Very important. I know we talk about it, but I think we really need to walk the talk as well. Yeah.
Dr. Elsie, would you like to give any final message?
No, first let
Yeah.
him give the comments also on this mineralizing angiopathy and the final comments. Both. Would nahi, he has to give. He's a star attraction, right?
So, on the final about the case, there are 3 things to consider and why these things happen. One is the anatomy. It's a very angular, it's a 90-degree angle of very fragile arteries. If you ever have done dissection on that area, then you understand it's very difficult to preserve in the cadaver these arteries. And so it's not unusual that they will break, torn, tear, anything like that. The other factors to consider are whether the patient had a previous history of an infection, as Biju was saying, in particular cytomegalovirus. This is a ubiquitous virus, affects many people. And if the patient has had an infections like that, or chickenpox, right, moya related, this may be on the same family. So the patient gets a very common infection. There is some vasculopathy already going on, and then you get an injury. And then there is a third factor, which is the genetic factor, which is what about if you have one of the mutations of FAR syndrome? What about if you have one of the mutations of a vasculopathy in general? So I think this is a combination of factors. It is a well entity, but it's not very common. And as you probably understand, there are a combination of factors that play a role. About the message, about the take-home message about the whole session. First of all, my eternal gratitude to Dr. Shefali and this group for the invitation. But the second will be that if you start a program like this, think about something more bigger, like a pediatric traumatic brain injury program rather than only concussion. That way, if the patient is moderate or severe, then you can absorb. Then as your group grows, then you can start dividing in different groups of specialists. And the second one, it is the need for education and prevention. And a lot of this means advocacy, an important role that physicians around the world have to take on these days, sometimes because we face situations like this, or sometimes because of war and conflict that they are affecting our globe at the moment. And so thank you so much again. Lots of work to do, and happy to be with you this time or any time it's convenient.
Thank you.
Thank you so much.
Heartfelt gratitude. Heartfelt gratitude. Arvinder, you want to say something?
Ma'am, I would just like to comment
You are
that,
seeing too many head injuries. You are seeing too many in particular.
yes, ma'am, last few months I have realized that in North India or maybe in India only, that we are getting admissions of moderate to severe traumatic brain injury patients. Mild traumatic brain injury patients are visiting just because if they have post-traumatic headache or if they get epilepsy. Then they visit the hospital and give a history that before 6 months that a child had a hit with a bat or he had a fall. Then we get a imaging and we get a small either something is there, or sometimes the MRI is normal also. So there is lack of awareness also in the majority of the population, because we apart from if we are planning some program, then their awareness should be there to because mild traumatic brain injuries majority I think is missing, but we are getting in the hospitals, in tertiary care centers also moderate to severe.
Absolutely, absolutely. Mahesh, our secretary AOCN. Any final comments?
It's a wonderful talk about Elsie. Really enjoyed the talk. And I think as we have been discussing, we need to increase awareness. Most of the time, this minor trauma is forgotten by the parents also. And it's not, we need to restrain then. Most of them, it's time they improve. That's also very important to reassure the parents that with time is going. Thank you.
Absolutely. And I
thank you
think
for your
for
kind
in the
words.
children's games, and also if you realize, like they have helmets and everything, we should put it. Thank you so much, Dr. Elsie. And we look forward for many more associations with you. And we get back now 2 weeks later. Dr. Ehsan Musa from Cleveland is going to be talking on surgical remedial epilepsies in children. Thank you so much. Thank you. Have a great day, Dr. Elsie. Thank you, Dr. Biju. Thank you, Deepak.
Thank you, and have
Thanks,
a good day, everybody.
Bye.
Biju,
Thank you.
contact me.
Biju is very difficult to contact. He's totally. You also contact me, Dr. Biju, with that list. Bye.